Cool. Thanks again for the invite. And it's a different topic to the rest of the ventilation day, as you can see. And I've got around half an hour, Luigi says, to talk about immunomodulation and ARDS. And most of the time, I'm going to kind of focus in on steroids for the first part of the talk, and then we can see. Right. So just a brief acknowledgement to my funders. I'm still funded through an NIHR Clinician Scientist Award. So these are my views, not necessarily the Department of Health and Social Care or the NHS. There's an intellectual conflict. I do immunomodulation research, and we are recently funded to do a steroid trial in the UK. So I'm sure you'll get emails from us to participate in that. And I'm also just acknowledging that I do advisory board activity, but none of those influence my research. They are managed as organizational research funds. So what I thought I would do is just a brief overview of the lung biology, and then talk a bit about enrichment and subphenotypes, because it's going to come up in different guises whenever we talk about immunomodulation, and focus in on steroids and some of the lessons that we can learn from successes or lack of in COVID. So anyone who turns up for an ARDS talk will probably see this slide. This is Taylor Thompson's lovely review from 2017. On the one half is the normal lung, and the other half is the exudative phase of ARDS, where you get the monocyte and macrophages getting activated. There's quite a lot of cytokines and chemokines getting secreted. Neutrophils kind of come into the lung, damage the endothelium, damage to the respiratory epithelium, loss of surfactant. So the normal fluid dynamics is altered, and the vascular permeability is altered. So you get exudative infiltration into the what is a normally dry alveolus, and then the interstitium, because of all of these cells and the chemotactic mediators, swells up. So you get a change in the interstitial kind of dynamics. And there is an increased risk of shear stress when you ventilate, so which kind of reinforces this kind of vicious cycle of macrophage activation, chemotaxis, and neutrophil influx, cell death, and then goes on. And one of the things that macrophages do is to produce TGF-beta. So later on in the disease process in ARDS, you would get to start to see some fibrosis. Anybody who's gone to medical school will remember TGF-beta, macrophage, and fibroblasts kind of talk to each other a lot, and you end up with a degree of fibrosis. And you can imagine from the number of mediators that are listed up there that immunomodulation is a thing in ARDS. We haven't quite worked out what it is and what the role is, but it is a thing. And steroids in this context is probably useful because we don't quite know what we're doing. Steroids does a lot of things. So that's why I think steroids get talked about a lot. And given the successes in COVID, it'll get spoken about a few more times. The second thing I want to just touch a base on about is the enrichment and subphenotypes. So you heard earlier on in the previous session that you want to find patients who respond to treatment and give the treatment to them. So that's the predictive enrichment of patients. And then you also heard about risk, and I think the idea that there is a mortality score for non-invasive ventilation, which kind of gives you a slightly different kind of context, which is if you have patients with greater number of outcome events in your trial, you can then probably make the trial more efficient. So the ideal scenario, which is kind of the basis of what I get up to, is can we actually have the two things together and in a clinically valuable way? And that's what we kind of propose as the treatable trait hypothesis. And here I just want to go through the basic premise of prognostic enrichment in ARDS RCCs so that you know what I'm on about. So that is Rohit Saha. He's a colleague of ours at King's, and he's also working as a PhD student in the group. And he kind of wrote this lovely paper in Chest. So the basic premise of any of the ARDS or any trials is that as the x-axis being the risk of an outcome, and x-axis being the baseline risk of mortality, and the probability of outcome is on the y-axis. And this line highlights the response to treatment. So the basic premise of any clinical trial is that as the risk of outcome goes up, you get prognostic enrichment, and therefore patients will respond better to therapy. And that's not kind of immunomodulation thing, it's there in ventilation trials, which I'll give an example next. And harms of treatment, we all think, and the trial design folk also think that it's constant across the risk, as in if your risk is high, you don't actually have a greater incidence of adverse events. That may not be true, but that's what we think when we design the trial. And therefore, you can kind of think this idea of if you have a treatment where the net harm is exceeding the net benefit, you have probably an intervention that's probably worthless. If you're in the middle, you just think, it's a low value thing, I don't quite know. I place NIV in that space as to what to do here. And then you got the right at the end of the spectrum where the treatment response is high, adverse effects is low, and that's your kind of sweet spot to design a trial. And when we thought about this in a very simple way, this is Rohit's paper. Here, the control arm event rate, which is the baseline risk of mortality, and then this is a treatment effect, which is odds ratio. What we expect to see is line going up this way, which we don't see in the ARDS trials published today. It's got roughly 50 odd ARDS trials, and the size of the blob is the sample size, and the treatment effect on average actually doesn't increase with increase in baseline risk, which is important because we think about ARDS designs as trial designs in ARDS and sepsis, AKI, etc., where you need to have a risk of an outcome event for your intervention to work. That may not be necessarily true unless the causal pathway for the outcome event comes from the disease that you are interested in. So that's what I think is happening in these two lovely examples. So this is example on the left is the PROSEVA trial. This is the prone position in ARDS trial where they have enriched a patient population with a P/F ratio less than 150, which is kind of severe ARDS. And then on the figure on the right is the EOLIA trial. Again, enrichment is inclusion criteria is PF ratio that is in the most severe end of the spectrum. So in a way, if you think about what they are doing here is, oh, by the way, you don't need a Bayesian reanalysis to tell me that extracorporeal ECMO works in a higher risk population. I mean, that was pointless exercise in JAMA. But this whole idea that you could have 5% absolute risk difference in a more severe population when you give right patient selected, you do an intervention, it works. And I think the way to think about this is slightly differently. Here, they are not looking for any baseline characteristic that increase your risk of death. What they're looking for here is a baseline characteristic of the disease in question, which is ARDS, and the more severe end of the spectrum, which is hypoxia, where almost all the deaths are likely to be attributable to the disease that you're trying to treat. That is very different from some of the PROVES trials where, if you remember, activated protein C, trying to recruit patients with an Apache score more than 25. Well, if you're old and you've got a few comorbidities, you'll get an Apache score that's pretty quickly 25. That is not the point of enrichment. I think this is a good example where inadvertently, but we have managed it to enrich patients that respond to a particular treatment. When we think about subphenotypes, you can't kind of not show this lovely work from Carolyn Calfee. The original idea, the basic premise being that there are discernible subgroups that we can't see within a clinical trial, and the authors have used a latent class analysis. And then Carolyn kind of goes on to show that you can identify two subpopulations of ARDS patients in the ARMA and alveoli trial, and these subpopulations separate out based on things that we kind of intuitively understand. So inflammation, which is subpopulation 1 has got a higher IL-6 and 8, and then lower bicarbonate and lower systolic blood pressure, i.e. bit of shock, bit of acidosis, and a higher inflammation. And that's what this inflammatory subphenotype looks like, and then the not so inflammatory subphenotypes looks like this. And I think sometimes there is one point that we all miss when we talk about these subphenotypes. It is not that the hypoinflammatory subphenotype doesn't have inflammation. Inflammation is there. It's just that it's relative to somebody else in that population. It's got a lower level of inflammation. So that's the difference rather than inflammation not being there. So some of the anti-inflammatory therapies may still work here, but the idea that the treatment effect is better in a more inflammatory subphenotype has been kind of shown by Carolyn, and that's the kind of the outcome table where you can see here phenotype 1 and phenotype 2 from the ARMA and the alveoli cohort, and mortality difference for the intervention and the organ failure-free days and the ventilator failure-free days. In other words, if you probably there is some degree of heterogeneity within the ARDS population, even in trials, in terms of their host response, and therefore, perhaps we can enrich them based on this. The challenge here is to basically see which of those are the right biomarkers, because what you don't have here is a diagnostic test for a hyperinflammatory phenotype. What you have here is data showing that the patients are different and they could be parsed into two groups roughly. And should the sample size be higher, you may find more subgroups because of the data being distributed in a non-normalized distribution way, because most of the biomarkers aren't. And I think here, often the questions the peer reviewers ask when you publish this sort of papers, which I'm going to show one of mine too in a few minutes, is that, oh, why don't you just dichotomize it? You can find responders and non-responders, and you can have a cut point. So basic 101 epi or data science, if you cut a variable into two, you lose 33% of the information contained in the variable. You need to have roughly 2 times the sample size to get the same idea. So sometimes when you see these sort of changes and you can't actually have a dichotomous number, you start to wonder why that didn't happen, partly because you need larger sample size to get that information. Okay, with that sort of background to a bit of biology, a bit of subphenotypes, let's talk for 5 minutes about glucocorticoids and ARDS. And there are 2 questions that come to mind. One is why, and 2, early versus late ARDS. Often clinically that's an important scenario or a distinct difference, and we've all kind of felt that challenge during COVID. Everybody gets steroids early on, or somebody who's persistently inflamed or on a ventilator at 14 days, do you give more steroids? Those are the 2 questions that often kind of comes up. So let's answer the first one, why steroids and ARDS? Again, going back to medical school pharmacology, glucocorticoids act through glucocorticoid receptors. It then does 2 things really. There is a transactivation and a transrepression. So transactivation is a scenario where if you give a steroid, it acts to the glucocorticoid receptor, gets onto the nucleus, and then activates inhibitory genes. So like IL-10 secretion and IK beta, that goes up, and then you get an anti-inflammatory cytokines being secreted. The second mechanism is the transrepression. Transrepression is you give a steroid, same glucocorticoid receptor, it then gets on to inhibiting the pro-inflammatory cytokines. As the dose goes up, you get both. What you also get is, as the dose goes up, is a non-genomic effect of steroids, which are not necessarily dependent on the glucocorticoid receptor. You can get cell membrane stabilization. Some of the glucocorticoid receptors are floating around in the cytoplasm, and that can be altered by the higher dose of corticosteroids. And the membranes that are unstable with the lipid drafts moving during stressed cell could be changed with glucocorticoid dosing. So there are a number of other things that happen. And these cytokine effects don't happen overnight. It takes a few days. I mean, once you know that you need to have a transrepression and transactivation of machinery to change the inflammatory profile, it takes a few days. That's easy to kind of think. There's no point in measuring cytokines tomorrow morning after giving steroids today if you're critically ill patient, because there's so many different ways in which the cytokines are produced, it ain't going to change. So that's just my rant. But and there are glucocorticoid independent mechanisms too that is relevant, and that may be probably easier to pick up when you think about biomarkers for the disease. Okay, with that kind of glucocorticoid background, let's look at the literature. So this is the PICO question for early. Early in the literature is defined as 0 to 14 days. So moderate to severe ARDS, give a low dose of corticosteroids, and the usual care is no corticosteroids and mortality outcomes. And I've just made literally a simple Peter plot this morning. So those are the studies, and we got studies starting from 1980s through to the Yesus Villar paper, which is DEXA-ARDS, which I'm going to show in a few slides. And as you can see, the sample sizes aren't particularly spectacular. And the point effect looks like it is probably benefiting ARDS with a confidence interval that straddles from 0.6 to 0.94. In other words, the variability isn't particularly great in the data. So in other words, what we are thinking here is that if you give steroids to everybody who comes in, the reason why I say everybody is the Steinberg paper is the NIH paper, which used late corticosteroids in ARDS. So this includes all of those populations. If everybody comes in and you give steroids, it's probably not going to happen in terms of improvement in outcome. And this is where probably the DEXA ARDS trial made a bit of an effort. So DEXA ARDS was a Spanish trial. So few points to make. Roughly 270 patients randomized, but they stopped early. 140 assigned to the intervention arm and 140 to the usual care arm. And what you see here is a decrease in ventilator-free days in the dexamethasone group, an all-cause mortality that is lower, 15% lower, ICU mortality lower, hospital mortality lower. In other words, if you give steroids to kind of patients with severe ARDS early on in the disease process, moderate to severe ARDS early on in the disease process, there seems to be a risk difference. The trial was powered for ventilator-free days. They stopped early. Therefore, the mortality signal is just an indicator. It's not going to kind of give you the same kind of, should you were to do the trial again, it's not going to give you the kind of 16% all-cause mortality difference at 60 days. What is important, though, is the difference from the Steinberg paper, which I'll come on to, where there was a late mortality signal. And that's the kind of the survival curve, as you can see, roughly 15%. So based on this information and the other information, we've designed a clinical trial. We haven't gone for this mortality difference of 15%. We've gone for a mortality difference of 8%, which is half roughly this, which we think is probably, if that, would probably be achievable rather than the 16% mortality difference. If you think about any drug in critical care with a 16% mortality difference, I don't think there's anything, right? I mean, there's nothing that happens. If you can get 5% in some, great. Even in cardiology trials, you don't see 15% mortality difference after the very early kind of trials of statins. After that, you're not going to see this amount of mortality differences, but it's a spectacular signal, but it needs kind of thinking through before we use it as normal clinical practice. Because I kind of made the distinction between early versus late ARDS, I just want to kind of bring this paper up. So this is lovely work from the NIH group where ventilated patients 7 to 28 days after the onset of ARDS, that's your population. It's not the early 0 to 3 days. They gave methylprednisolone. They didn't give dexamethasone, which is what the DEXA ARDS trial did. And then the usual care of no corticosteroids, and the outcome was 60-day mortality. There are some interesting things that happened during the process, during the design. I'm sure our US colleagues may have points to add, which is, there are some sample size recalculation that went on, and then the ICU practice changed significantly. And if you follow these patients up, the patients who got steroids got reintubated more often. And this kind of begs one of those trial design questions, right? If you're going to design a trial, here there was one argument that the steroids were stopped early on in the intervention arm, and perhaps that contributed to the early rebound. So if you're going to design a trial, you'd think, well, how do I use that information to design a better trial? And I think that's where some of these nuances around how long do you need to give steroids and do you taper it or not come in. I'm not even going into the sepsis literature field with the kind of similar sort of arguments. Okay, let's think about, often what needs addressing question comes in when you design a trial. And predictive enrichment, again, I'm just giving you some examples of what people have thought about and done. The first one is the Tony Torres work in severe community-acquired pneumonia, and the high inflammatory response they used a CRP greater than 150. And they kind of show some signal with that. There are some challenges to the trial, 10 years to complete a CAP trial, etc. But, they've thought about it. They've highlighted a point that you could use CRP, which is measured everywhere, as an enrichment marker. And the one below is the VANISH trial reanalysis, where if you use the SRS subphenotypes of sepsis, you can probably get a steroid signal. It's very difficult to kind of get a gene expression profile done, then randomize during ICU working day, let alone the weekend. So it's not going to happen for a few years. There are other things that people have talked about. In asthma and COPD, there are some steroid sputum gene expression signature using 7 selected targets that could enrich your population for an intervention while reducing the adverse effects. And I think asthma probably is one of those spaces where there's a clear-cut biology. You've got the Th2 asthma versus non-Th2 asthma, and within the Th2, you've got subpopulations based on simple measurements such as eosinophil count and based on some sputum profile. So it's probably asthma is where we kind of currently asthma where it is today is we currently are 12, 15 years ago. So I think we got a lot of catching up to do before we get anywhere closer to this. But this last kind of possible enrichment often for steroids is an interesting one. I don't know, many of you may not ever think about this. If you look at your routine blood results, you get all of these values. RDW, red cell distribution width, and anemia, people have talked about it. You get platelet distribution width, and alongside that, you get the monocyte distribution width. And the monocyte kind of study, this is work from Djali Anand's group, where they're thinking about using this as a probable precision marker for steroid response. So it is possible to do precision medicine, probably harder given where we are in terms of the in vitro diagnostic space to use it at the bedside. Right, and I'm just going to kind of bring this kind of slide up just to close the steroid debate. So this is again from the CHEST paper. What Rohit did was to include all of the clinical trials in ARDS and then use that information to think about it in a Bayesian way to see whether we should prioritize steroids for a new RCT. And Rohit has done that for a couple of other interventions as well, like APRV that Luigi is interested in, and NIV. So if you're interested in kind of making an argument of whether you should do a clinical trial, have a look at this paper that Rohit has led on. And here, what Rohit pointed out is that actually, if this is the prior probability, based on these trials, our prior probability has changed so much that you're likely to have a positive trial with a posterior probability of 99.7%. Which, by the way, is higher than the SGD posterior probability reported in JAMA last week of likelihood of a positive result. So it is possible that the steroids might give us something if we do the right trial and not use it indiscriminately in patients. So in the last few minutes, I just want to touch upon a couple of things from KOBIT. So this is data that we put out. I just want to focus in on here, which is the one of the cytokines we always talk about is IL-6, IL-10, and IP-10. And here we show that a triad of these 3 molecules could identify patients who are at higher risk of adverse outcomes, partly in terms of the disease progression and in terms of host response. They often are antibody negative. And within the REMAP-CAP trial, we used a similar sort of idea and went on to define subphenotypes purely on serum cytokine profiles. And we highlight 3 subphenotypes. And I want to make 2 points. The first point is this. Subphenotype 2 and 3 are the more inflammatory subphenotype. They've got heightened IL-6, IL-10, IL-8, and subphenotype 2 has got raised IL-4, IL-5, GM-CSF. But they have the lower mortality. So inflammation and mortality needs to be kind of thought about slightly differently because cytokines don't act by themselves, they act in a network. I'm happy to kind of take any questions from this paper, but And what we see here are these two more inflammatory phenotypes being harmed potentially by convalescent plasma. We often talk about benefits of an intervention. If we were to flip this around and say, actually, some interventions could be harming patients if we could exclude them rather than trying to chase after responders or potential benefiting patients, that might actually give us an easier route into patient selection. And the reason why I'm bringing IL-6 up is a work that I led alongside the WHO, where we show the value of giving IL-6 receptor blockers in COVID-19 and a mortality benefit and non-mortality signal as well with ventilator-free days. And the last biomarker thing that just might be worth thinking about is this work led by the group in Greece. Evangelos is the senior author, where he talks about using anakinra and enriching patients based on SUPAR. We're not anywhere near this space in all-cause ARDS, but worth thinking about some of the biomarkers that have been used previously in clinical trials might kind of help us get past the in vitro diagnostic challenge to enrich earlier. So what does these three papers have anything to do with ARDS talk that we are on about? So I'm just going to go back to mostly Caroline Calfee's work, and this is a summary that Andy Conway-Morris, one of colleagues in Cambridge, wrote an editorial on, where the x-axis is essentially, it's part of a heat map. The heat map is a page long, so I've just taken up half of it. So the x-axis are the different trials, which are ARMA, Alveoli, FACT, SAILS, HARP, and Early and Valid are two cohort studies from the US. And the y-axis are the different biomarkers. And I've kind of highlighted a few biomarkers that are common across these studies, and they are often increased. So IL-6, IL-8, and the soluble TNF receptor 1. In other words, all of these subphenotypes of ARDS seem to have kind of three roughly common signals, mostly on the innate immune system, partly driven by the sampling interval, but they seem to have greater IL-6, greater IL-8, and greater soluble TNF receptor. So potentially highlighting some of the signals we could pursue if you are going to target with immunomodulatory therapies. So with that, I'll kind of summarize. So early all-cause ARDS, there is definitely a signal from a DEXA ARDS which we need to replicate. Late ARDS is more of a challenge, and there are so many uncertainties. It needs really a phase 2 trial, but nobody would fund it. But there are potential signals for targeting cytokines in all-cause ARDS. We need to kind of design clinical trials, not just give these treatments as part of routine clinical practice. Thank you very much.